Dr. Ramey, you're leaving at 11:30 this morning, so I'm going to pose this first question to you. Is it asthma or asthmas? Because asthma means different things to different sector of people. For some, never visited ER. For some, always at the ER. As a pediatrician in the emergency department, can you tell us what the typical cases that you see on a typical day or night?
Well, I'm not a primary care provider, so you would think that I wouldn't provide primary care, but a lot of times I do. And I think that's one of the biggest problems is that a lot of these kids don't have access to good primary care, so they don't know how to take care of their disease. And so we see a skewed population of kids that come to the emergency department that don't know how to take care of their asthma. And you'd be surprised how many times a day I'll see a child who's using their preventer med as needed, or they're using their albuterol every 2 hours and didn't realize that they needed to be at the emergency department a long time before that. Or they'll be with one parent for the weekend and not even have their meds with them. So again, I see a very skewed population, but I think that it would be, if more kids had access to better primary care, then a lot fewer of them would end up in the emergency department.
Thank you. Richard, children all over the country suffer from asthma, and while medication can help with symptoms, the best defense is to eliminate the triggers that cause the attacks. You've been co-leading the Asthma Coalition the past 2 years. The coalition had weekly discussions over several months before deciding what things to move on with or what to focus on. What things did the coalition decide to focus on and why? Can you use the mic closer to you?
Hear me okay?
Yeah.
In the early weeks, we spent a lot of time discussing all kinds of points of view. And one of the things that we talked about early on was eliminating the areas that were already, we felt, were very well covered. We recognize that a coalition has limited resources and limited ability to interact with the community. And so we wanted to focus on some of the things that maybe were otherwise not being dealt with other places. For instance, the drug companies have spent billions of dollars advertising their medications for asthma and for allergies and things that are related. Many people knew where to find their doctors, although certainly it could be more open and all those things, but that was something that others were working on. And they've spent trillions of dollars in the last 50 years cleaning the outdoor air. So while the last 50 years has brought us great strides in all of these areas, asthma has increased by nearly 400% over that period of time, where all of these capabilities were being expanded and worked on. So we eventually asked the question is what's not being done and what a small group of volunteers with no funding and little time could focus on and could make a meaningful difference to asthma and the supportive stakeholders that are involved in asthma care. Research supported the conclusion that the indoor, where people spend 90% of their time, is a potentially serious problem for asthmatics that's not being well understood. It's not heavily focused on by the medical community, and it's underserved by the public sector. It sounded like a good idea to us for being further consideration for focusing on the indoor air. Once we narrowed our thoughts to the indoor air through discussion, we organized most of the common asthma triggers that would be affected by indoor air into airborne triggers, surface triggers, and the humidity control. In the home, the remedies for these concerns are mostly family self-management issues. And they require little capital, but some understanding. The asthmatic self-management before emergency intervention is required, fit neatly into that package. So we included as the fourth element that we were working on, the making sure that people knew, had a good asthma plan, and knew when to seek emergency care when necessary, but how to head it off before it was necessary.
Thank you. Can you all hear from here? Can you hear the panelists? Okay, if you can, please let us know. We'll try to increase the volume. Sarah Lovelace, you are the nurse case manager and the high-risk asthma coordinator at Georgia Pediatric Pulmonary Associates. What does that typically entail? And should we consider every admission of asthma as a significant event or a failure of medical care? How do we improve the standards?
Sure, thank
Can you take the mic towards you? Yeah, or speak close.
you.
Yes,
Better?
thanks.
Okay. At my office, Georgia Pediatric Pulmonology, we're the largest pediatric pulmonary group in Georgia, so we see a lot of asthma. And we developed a high-risk asthma program that right now has about 500 children in it. Kids get into that program a lot of times based on whether they've been admitted to the hospital, the ICU, multiple emergency room visits, been on a lot of very high-dose inhaled steroids as well as systemic steroids, prednisone, Orpred, things like that. The goal of the program really is to partner with families, primary doctors, emergency rooms, to sort of tie loose ends and communicate about the child's asthma care. Again, like Ms. Passon said, working on the asthma action plan and sort of making it a little more real for families, how to implement it, what does it mean. We, like Dr. Remy, we see a lot of kids and families that need a lot of education on what to do on a day-to-day basis with their asthma, as well as when they have an exacerbation. So the high-risk program involves a nurse that calls monthly and talks to families. And really, I have found that asthma education is really important, but building relationships with people, parents, children, is just so critical in getting your point across. So, and you asked about asthma admissions. Every asthma admission is important and matters, without a doubt. We actually do something now called an asthma hospital quality review, where we sit down as a team with doctors, nurses, parents, and we go over a lot of the key elements of the admission. And I won't go into all the details of that, but the bottom line is we sit down about every single asthmatic child, whether they're in the high-risk program or not, and we talk about what got them there, what got them to the emergency room, what got them admitted, and we look at things that we can do differently to change that and stop it from happening again, and we look at things that the family can help us do as well.
Great. Before we move to the next question, I would like to give a shout out to Dr. Matthew McKenna. He's our medical director at the health department. And I'd like him to let us know what he expects to learn from the session today, quickly. And I'm coming to more of you. Next might be your turn.
Well, first of all, I just want to say thank you to the panelists for being here today and educating all of us as well as me about the ins and outs of asthma. We've had a model for understanding this in terms of looking at it as a three-legged stool: the outside air quality, the inside air quality, and medical care delivery. And it's really exciting to me to be able to hear from all these different perspectives about how we can make each of those stool legs a little bit stronger in terms of addressing this issue. It's also exciting to me because given the breadth of, so to speak, no pun intended, but given the breadth of the various people involved in outside environmental air quality, housing and inside air quality, and medical care, we have an opportunity to hear from a large number of different types of people with different expertise. So I always learn something from that, given that I'm, classic kind of medical doctor, to hear the other perspectives that will be brought forth today. So that's what I plan to learn and I'm excited about hearing.
Looks like you were prepared. So, Danella is our other Asthma Coalition co-chair, and Danella, you're a pharmacist. Pharmacy is the vital touch point before a person gets to their home. How does selecting a pharmacy provider impact health outcomes? You're also leading the Asthma Coalition, specifically the treatment committee. What is the goal of that treatment committee, and what have you accomplished so far? And how do you feel better placed as a pharmacist in convening the healthcare providers to improve quality outcomes?
Okay, you gave me 3 questions rolled into one, so guys, if I don't remember the 3, you help me remind me. First and foremost, being a pharmacist for 21 years and not practicing pharmacy in the traditional sense, but managing over 60 pharmacists, it's very critical that you leverage me appropriately, because pharmacists as a community-based model oftentimes is where that patient who is not well controlled is going to go to for some added care. And speaking and listening to the passings, I do recognize, and you medical people in the room, providers in the room, we should all recognize that integration of care was non-existent when we think of Brennan's demise and what we could have all done to prevent that from occurring. So I think it's important as it relates to being in the pharmacy space that I educate pharmacists. I begin to give them newfound awareness of how they can improve that patient-provider relationship, almost serve as a navigator of care when they recognize key breakdowns in an asthma plan or a treatment guidelines, that they take the time to stop what they're doing and to connect that provider with that patient's needs. I think that's critical. If we do that in the pharmacy space, you will see a decrease, hopefully, in the space called ER visits. So that's one component. The second question, I think, was, you know, as far as the treatment committee, what's our goals and what do we hope to accomplish? For me, as a pharmacist, I always hear from the various providers, you know, who they're connecting with as it relates to improved health outcomes. I didn't hear about the school. We got Lynn here today to talk about that. But I always think we miss the opportunity, if we're thinking about integrated care, to leverage the community pharmacy. In the downturn where there were losses of jobs and, you know, no one had health care, people use that community pharmacist almost as a segue or this pseudo healthcare provider, primary care provider, to address some of their concerns that maybe they would address in the emergency room or in a healthcare provider space because they didn't have the insurance to pay for that visit. So if I don't do anything but accomplish this with my presence here as a pharmacist to say we can't talk about care and improving asthma outcomes unless we focus on all facets of the healthcare paradigm.
Great.
And your third question, you did have a third question there. I can't
How are you
remember.
better placed as a pharmacist to convene the healthcare providers?
I think I can only talk about my company, and I'm not here to represent my company. I'm actually here representing as a volunteer. But I will tell you, at my company, we think about integration. I was just talking to Margarita about integration has to be the way community pharmacies deliver care. We have to find a way to take that pharmacist away from the dispensing role solely into the space where they can talk to Susan and say, have you know, if this happens in an emergency situation, this is what you need to do. Do you have an asthma plan? Knowing the school nurses, believe it or not, in the community setting, we should be able to do that. Understanding who the emergency room physicians are because we see the prescriptions come through, and connecting those dots, visiting the emergency room, visiting the healthcare providers. We can do those sorts of things. They all have space on their docket to deal with the pharmaceutical companies, but getting to understand the needs of the provider group, understanding the gaps around education and being able to improve those relationships and those experiences for the patient in the pharmacy setting.
Great. Before we move to the question to Lenny, I do want to recognize Deshaun Industries. Can you come in front, Deshaun? Deshaun has been our volunteer for a year and a half. He's been our volunteer a year and a half, very patient, very composed, has always brought my blood pressure level down because anything up and not right, he knows how to calm it down. You would want him by your side in your team. He is looking for a job, and we know he's been excellent. If you think the Asthma Coalition has come so far, he's a volunteer. He's a volunteer and doesn't want to let go of us because he believes in the cause. So thank you so much, Deshaun, for your dedication and commitment. Lenny, you're from the Atlanta Housing Authority, and people here are wondering, wait, what does asthma has to do with the housing? What has Atlanta Housing Authority done to promote healthy living environments? Can you tell us more about the clients you serve, and what is the process of reaching out to them?